Okay, good evening. I am doing a recorded video on cervical cancer screening. So you can have this information with me explaining it to you. I'm trying to make sure that the recording is happening. Let me stop sharing for a moment. It is recording. Okay. So I am Dr. Linda Goldman, and I'm a women's healthcare nurse practitioner and a family nurse practitioner. The objectives for this talk is to go over the anatomical structures and techniques that are related to obtaining an adequate cervical cytology sample, also known as a pap smear. We do a lot of pap smear screening as nurse practitioners, and we're kind of in the middle of a flux with different types of screening and techniques and how often we should be screening people. And then there's a whole other section of what do you do if you get an abnormal result. Mainly the focus of this is on doing the initial screening. These slides were done 2 years ago, and things change and they're always in flux, and we have guidelines coming and going right now. So I'm going to try to keep it more general, but I think that I've decided to go with the ACOG guidelines, and I'll talk about the different guidelines in a moment. We have the ACOG and the USPSTF guidelines are also available to you. I don't have any financial relationship to anything. So basically, it's important to understand that cervical dysplasia, which are abnormal cells on a pap smear, it's not cancer, but dysplasia means abnormal cells, um, and cervical cancer are related to sexually transmitted high-risk human papillomavirus. So cervical cancer is essentially due to human papillomavirus or the HPV virus. And most people are exposed to HPV within the first year of becoming sexually active. These statistics are lower in recent years because we've had more people becoming immunized against HPV. Now that insurance companies are not covering it in the way that they used to, we might start to see less coverage as far as the primary prevention of using immunization to prevent exposure to HPV. We really want to get this immunization done prior to the patient becoming sexually active. So while they can be given to everybody up to age 26 and then other people up to age 45 in some conditions, it's most effective if it's received by people before they become sexually active. And it's nice to do it at the middle school visit. Hopefully, they haven't become sexually active at that time. 9 is usually the youngest age we give it at. So those are important points to remember, that while we can give it afterwards, we can't really depend on it doing anything for our patients as far as preventing cancer in all the cases. It may reduce it, but if someone's already exposed to high risk HPV, they're already exposed to it, and it doesn't, giving an immunization doesn't take that exposure or that risk away. Normally, people are exposed to HPV, like I said, within the first year of becoming sexually active. Um, and most of the time, in most people, our bodies eliminate the virus. It takes care of it. Our immune system kicks in and prevents that virus from persisting. What is important to know is the type of virus that persists is the ones that can cause cancer. So over time, persistent HPV is what we're concerned about. We're not just concerned about finding HPV and treating it and saying it's all gone. For number one, we don't have a treatment for it. We have treatments for cervical changes that occur in response to this infection, but we don't look for HPV infection to treat it because there's nothing to treat it with unless we have some kind of abnormal changes on the pap smear. Hope that's clear. But just keep in mind, and I have in yellow, HPV that persists or progresses is associated with cancer. HPV that comes and disappears and is gone doesn't cause problems. So that's where we need to be aware of people who have persistent HPV. That's why we test for it over time. It's usually a slow growing issue. So the median age of cervical cancer is 47 years old, and it's mostly associated with high risk HPV virus, human papillomavirus. The two most high risk of the high risk group are type 16 and 18. HPV is numbered, there's like 100 and something of them. And they start with HPV number 1, which is like a wart on the finger. And then they just name them. Oh, this is the first one we discovered, it's number 1. The latest one we discovered is maybe 131. I don't know where we're at right now. So that's why there's these numbers. So HPV 16 and 18 are the biggest culprits in being associated with cervical cancer. 70% of cervical cancer is caused by these two types. There are other ones that are high risk as well, and I'll talk about those later. But the buzz ones to remember in your head are 16 and 18, high risk. Young women do not need to be screened. And the reason is, as I said, most people are exposed and most people clear it. We're only concerned about the people who don't clear it, and they're not going to find them. We're not going to find them until those people are older. So when people first start having sex until 10, 20 years later is when it may manifest into cervical cancer, assuming you have an immune competent patient. If you have someone with HIV or some other immune deficiency, it may progress faster. So we don't screen young women under age 21, no matter what age they became sexually active, because it's unnecessary. And once we find it, we're obligated to treat it, and that treatment can bring more harm to the patient than it can benefit. So we don't even want to look for it, because if we look for it and find it, we have to do a treatment that might not benefit and may actually harm our patient in terms of causing an incompetent cervix that won't stay closed during pregnancy. So those are the things that we need to weigh. Most high risk HPV resolves on its own without any kind of treatment. We just need to give the patient enough time for the body to kick in and clear the infection. So we've got this dude, George Papanicolaou, and George Papanicolaou discovered something called a pap smear. Prior to him, we didn't know how we could screen women for this disease that was killing them. So he came up with a pap smear for Papanicolaou. And that's a cervical cytology test where you take a scraping of the cells off of the cervix and send them to lab techs, and they look for certain changes, and I'm going to get into a little bit more. We now have additional tests that are related and can do above and beyond what just the cytology test does, where we can actually test for high-risk HPV virus. I keep calling it HPV virus, and that's really saying virus twice. It's human papilloma virus, HPV, and I'm sticking virus again at the end. So a screening test I just want to mention for a moment, because a pap smear is one of the most ideal screening tests that we have in medicine. It still is. And a screening test is where we can screen a large group of people and identify a subset of those people where we're going to do further diagnostic testing, and then we can treat them to prevent a disease. So when you think about a pap smear, if you had 100 people and you screened all of them and you found, well, let's say you had 10,000 people, and out of those 10,000 people, you found 40 that had abnormal changes, you can pull those patients and you can then do a diagnostic test, normally called colposcopy, identify who has actual changes on their cervix, treat their cervix so the changes do not progress to cancer. And that's why a pap smear is such a great screening tool, because we can screen everybody, find these people that need further diagnostic testing, test them, treat them, and have them not get cancer. So it's wonderful. We want high sensitivity, which identifies true positives. We want a test to be high specificity that will identify true negatives. We want to be able to have early identification and should be easy to perform and inexpensive. And a pap smear ticks all those boxes. If you think about ovarian cancer, we don't have a way of screening people inexpensively and easily. By the time we find ovarian cancer, most of the time, it's progressed and it's quite large and is often spread. So we can't find it early enough to treat it to prevent, further morbidity and mortality. But with a pap smear, we can find very early changes, treat them, and stop them from progressing. So again, we're not killing a virus or treating a virus. We treat abnormal changes that occur on the cervix in response to high-risk HPV. In the 1940s is when Dr. Papanicolaou came out with his cervical cytology testing, and our number of people who have died of cervical cancer has greatly decreased since then. So these are the guidelines from 2020. They may change again slightly. So age 21 to 29, it's recommended to do cytology every 3 years. Age 30 to 65, we do cytology with HPV co-testing every 5 years. So we're doing 2 tests every 5 years. At age 65, we don't have to continue screening unless someone has a history of abnormal pap smears. If they've had a lifetime of normal pap smears, they can have their last one at age 65. If they had a history of being treated for abnormal pap smears, we need to continue to test them for HPV changes, related HPV changes, for 25 years after their last treatment. So it's not only going to be age 65. And some people who have been impacted need to be continued to be tested as they become older. Abnormal pap smear results mean that the patient needs to present for further diagnostic testing, which is called colposcopy with a biopsy. I have some terminology for cytology, and those can be done by a smear or they can be done in a liquid-based bottle. And there's called low-grade squamous intraepithelial lesion, which is LGSIL. We have high-grade HGSIL. We also have atypical squamous cells of undetermined significance, also called ASCUS. And then we have atypical glandular cells of undetermined significance, or AGUS. AGUS is super scary because that can indicate endometrial cells or cells that have come maybe from the ovary and are appearing on the cervix and going into our liquid pap container. And that can actually be endometrial cancer, or it could be ovarian cancer, or it could be glandular cells of the endocervical canal. So we kind of need to know if the person is menstruating at the time of the pap smear, or where these cells are coming from. So if we have a patient with AGUS, we automatically have to go to colposcopy with an endocervical biopsy and an endometrial biopsy to see where these abnormal cells are coming from. This is not very common, but I just want you to know, because ASCUS is very common and less worrisome, but ASCUS, even though they seem like they're similar, AGUS can be really serious. For biopsy sample, we use a cervical intraepithelial neoplasm nomenclature, or CIN, 1, 2, or 3. 3 is the most significant changes. We have carcinoma in situ, and we can have adenocarcinoma or adenocarcinoma of the cervix, and that can show up on a biopsy sample. We can also have we have CIN, which is cervical intraepithelial neoplasm. We can have vein, which is vaginal intraepithelial neoplasm. VIN, which is vulvar intraepithelial neoplasm, and PIN, which is penile intraepithelial neoplasia. So that's a way, neoplasma. So that is a way of um, stratifying the results, the least significant changes to the most. CIN3 could indicate carcinoma in situ, and it could even be beyond that. So for the anatomy on the cervix, we have the endocervical canal, which is the part that goes up from the outside of the body to where the cervix is closed by the uterus. This is the cervix that dilates during labor and delivery for the passage of the baby. So on this picture, this is a colposcopic image taken through a colposcope, which magnifies what you're looking at 13 times. This is the os. This is the opening to the cervix. This is quite magnified. And you can see there's this kind of white tissue area hanging down, it looks like. This is a light reflex. Ignore that. This is because there's a light at the colposcope and we're looking with binoculars, and this is just reflecting because this tissue is moist. But it's this white around here that I'm most interested in. And that is normal. It's called normal metaplasia. And the inside of the endocervical canal is bright red tissue. It's 1 cell thick. And the squamous tissue on the outside of the cervix looks like the lining of the inside of your mouth. Now, when you magnify it really large on the cervix, you can actually see more intricate details. So we have columnar cells underneath, and you can see these are columnar cells. They're more red because they're 1 cell thick. They're on a column. They stand up straight. I have pictures of those in a minute. And then over time, as these tissues, these columnar tissues are exposed to the acidic environment of the vagina, the squamous flat cells start to tile over them. And as they do it, it turns into this white tissue up in here called squamous metaplasia, which is normal. However, these tissues that are changing, they're actively going through this metamorphosis of the tiling being laid down on top of the columnar cells. This is an area that's very vulnerable to HPV and very vulnerable to becoming displaying abnormal changes related to HPV, which can first start out as looking at a low-grade lesion or a high-grade lesion. So this is the area that we want to sample when we do cervical cytology or pap smear screening. We want to get a sample of this tissue. This looks like mucus, this looks like mucus, but I'm looking at this in here. And this again is the os. I have more pictures to show. So a pap smear is a screening test. There's a false negative, meaning you get normal results. It could be 15 to 40% of the time. We try to reduce that to as low a number as possible of having false negatives, because we don't want to tell someone you've had a normal result when they really don't, because we're missing people, right? Over half of the errors are due to a sampling error because the operator, the nurse practitioner, didn't sample the correct area or use the correct technique or the correct equipment. And the other half is due to lab error. So optimizing the results of a pap smear, ideally we want to get it somewhere around day 10 to 18 of the cycle, but that's not mandatory. If you have someone sitting in front of you in your office and they need a pap smear, do a pap smear, because if you tell them to come back, they might not. So we want to kind of do it anytime. We prefer not on the menses, but we can do it if they're bleeding. We just have them, if they've used a tampon, that's great. You have them take the tampon out right before you do it, or you can take the tampon out. And then there's very little blood involved, and go ahead and do the pap smear. Put a towel underneath them, and there is just no problem. You can do it with someone on their period. Some people are very heavy, having very heavy periods. They might not want to do it. They might not want to have an exam, and then you could reschedule them. But they're not going to have an exam anyway. And most of the time, they don't want to come in unless they're having a problem. It's best if the patient has avoided any kind of creams or gels, at least in 12 to 48 hours before you do the exam. But again, that's not mandatory either. These are just most ideal conditions, and no intercourse for 12 to 48 hours. On the lab, is it a good lab? What kind of quality control factors do they have? You have no control over what your clinic has, this lab has, is there, that they're using. Um, but you might end up being an owner of a clinic one day. So be aware that some labs are better than others. The goal of cervical screening is to identify HPV-related abnormalities that are likely to progress to invasive cancer. So we want to find early lesions that we think are likely to progress to be severe lesions. Okay? And we want to just avoid destructive treatment of lesions that are not likely to progress to invasive cancer and harm the patient. So that's basically what I've already said. We want to identify people with HPV that is persisting, especially that which we think has a high risk of becoming cervical cancer. And we want to avoid treating people for very not high risk conditions and issues that are not likely to progress to cancer. And that is, young women generally are not going to progress to cancer at that point. This is the equipment. We use these bottles very commonly. There's another brand that's about half as tall, and that's kind of what we're using more. We're not using glass slides anymore, although you may see it at some sites. We use a large Q-tip to gently wipe away any discharge or mucus that might be there. This is called a broom, and this part goes into the cervical os, and we turn it to get a sample. This is called an Ayers spatula. We don't use wood anymore because we're using these liquid-based chemicals, and the wood, you can't use that with the wood. And if you use the stick, the spatula, you also need to use a cyto brush. So if you could use just a broom, or you can use a cyto brush and a spatula. You can also use a cyto brush and a broom, or just the broom, depending on your patient's anatomy. So here's another picture. This is the opening. This is, or called the os. This is red around here. You see this top lip up here, how red that is compared to the pink coloration here. And she's got some kind of discharge going on in here. This looks like very watery discharge. This looks very much to me like spin barkeep mucus. So she might be at her mid-cycle. She might be close to ovulating here. Just a side note. If you look at this cross section, so this is a cervix standing up on end. So this opening looking down to the ground is this opening looking straight out at you. So if we could look up inside this canal, this is what we would see. So this is the endocervical canal, and you get there by going through here. Inside here, we have endocervical glands, also called crypts, and these glands make mucus. That's their job. They're goblet cells in there, and they make mucus. This is inside of the uterus up here. This is inside the endocervical canal, and this is the os. Squamous cells. Squamous cells are the cells that go around the outside of the cervix. They go on the walls of the vagina. They line your mouth. They're flat. They stain either pink or blue, and there's no significance to which color they stain. But they have a relatively small nucleus and a large amount of cytoplasm. Don't worry about the colors, doesn't matter. Okay, they're large and they're flat, and they often fold over on themselves. So these are normal squamous cells. And on here, those represent these cells out here on the body and all out here. Okay. The next type of cells are squamous and columnar cells. So remember I told you that the endocervical canal is lined by these columnar cells. They're called that because they look like columns. Their nucleus is right here at the bottom, and then they stand tall. They stand straight and tall, and they line the endocervical canal. That endocervical canal is one cell deep. So there is one cell between what your eye sees and the blood vessel with red blood inside. So they look very red. These squamous cells lay over the top. They like tile over the top of the columnar cells in this process of metaplasia that I described a little bit ago. So these are columnar cells, one cell thick. They're red because the blood vessels are underneath. And these are the squamous cells that have tiled over and made a thicker, darker pink color, putting more cells between your eye and the blood vessel, so it appears pink. This is a picture of the junction. So this is the same look that we had before. This is going up the endocervical canal, and this is the side of the cervix, and this is the side of the cervix. So here you could see one cell thick columnar epithelium lining the endocervical canal, and this is multiple layers of squamous cells that have tiled over the columnar cells, and they're thicker and they appear pink. One cell appears red. So the squamocolumnar junction can be in different locations on different patients. And one of the things we need to do is determine where to take a specimen from. So this is the squamocolumnar junction on this patient's cervix. This is her os, or the opening to her cervix. And this are squamous cells. It's pink. There's multiple layers between what you see and the blood vessels below. And these are the columnar cells, and they line partially on the outside and go up into the endocervical canal. On this patient, this all looks pretty pink around here, and we have columnar cells inside the os. We don't have any on the outside. I would have to be able to focus up and down and see what's going on up here, but I can't tell right now. But I can see that up in here is where the endocervical columnar cells are. So where is that junction? Where is the place where the pink squamous cell comes in to contact with the red columnar cells? And if you don't see it on the outside, it's up inside the endocervical canal. Here's another picture of the junction. This one is super defined. This is squamous tissue. This is columnar tissue. These pictures have all been taken with different kind of lighting, so some of it looks really different and kind of weird, but this is the endocervical canal. This is the opening. And again, that's the part that will dilate and let a baby out. Another picture of an endocervical canal is right here, and you can't see any squamocolumnar junction at all. All of these white splotchy things, these are all light reflex from the light on the colposcope reflecting off the moist tissues of the cervix. So all of this is squamous tissue. It's all been covered over, but up inside the canal, it's not. So her squamocolumnar junction is up inside. So for someone who has a squamocolumnar junction like that, or like no, not this one, like this, you want to make sure to use a brush or a broom that can go up inside the canal to sample the junction. On this patient, you could use the air spatula, and you want to make sure you scrape along this border all around the whole cervix. We can't see all of it. Or a broom, you could insert it on here, but you also need to smush it around here to sample this tissue. This needs something up inside, so the broom will go up inside, but you also want to make sure your broom reaches the junction out here. Same with this. There is nothing on the outside, so this definitely needs an endocervical sample, and you can use a brush or a broom for that. This is completely squamous tissue. This is looks pretty estrogenized here with the rugae that we could see. But this is a very small, tight opening, and you would probably be able to insert a cyto brush in here easier than a broom. A broom is kind of too big to get into this tiny opening. But again, there's no junction on the outside. It's all moved inside. This is a picture of what happens with normal squamous tissue, normal squamous epithelium. This isn't fitting on here very well. Mild dysplasia is when things start to change into some abnormal tissue. And then we have moving towards moderate dysplasia to severe dysplasia. Then we have carcinoma in situ, and then we have invasive cancer. So how this works is we have many layers of normal cells. These are the squamous cells on top that we scrape away with the broom or the air spatula, and we send them to pathology and they look for abnormal changes. And they have normal cells have a small nucleus, a large amount of cytoplasm. As they become dysplastic or abnormal, the nucleus becomes larger and the cytoplasm becomes smaller. As we move into moderate and severe, we have basically until the nucleus takes over the entire cell and there's really no cytoplasm in here until we have full-on cancer cell. So we call it mild, moderate to severe dysplasia. When all of the cells are involved, it would be carcinoma in situ. And this is the basement membrane. So these are all normal cells up against the basement membrane, but now they're getting more and more abnormal, and we're in carcinoma in situ. So this full thickness of tissue are abnormal cells, but the basement membrane has not been breached. When you get to invasive cancer, that's when the cells have invaded past the basement membrane and start invading into the surrounding tissues. So those are the basic differences in the progression. This is called leukoplakia, which means it's a white lesion, and it's pretty large. This is different than the normal metaplasia. The normal metaplasia is on the side here where these are changes. This is leukoplakia. If you see someone's cervix and you see a white lesion that just sticks out at you, that person needs to be sent for a visual abnormality of the cervix for colposcopy to see what is this thick tissue. You would pap it, you would scrape along the whole thing and make sure it went into the pap smear sample, but you would also send them for colposcopy so someone can take a look to see if there's any cancerous or precancerous changes on this leukoplakia. So when we are doing evaluation of cervix, it's not just to do a test. If we see a visual abnormality, we act on it. So just to remind you, this is the broom that could fit into the os and a very small, very thin cyto brush with an air spatula. So you can see the bristles on here and a very narrow wire. And you insert this right into the cervical os. This is another picture of another brush, and the brush goes up into the endocervical canal. You make a 180-degree turn. If you spin this a bunch of times, it can cause bleeding. So you just do like a half a turn. If you really want to do a whole turn, you can do a whole turn. But it really only needs a half a turn because as you turn it, whatever's here is going to be up over here, and what was over here is going to end up over here. So you're going to get the entire sample done with a half a turn. This is an IUD string sticking out of her os. So that's just kind of what you see there. But if you want to do a full turn, that's fine with a cyto brush. More than that, you're going to get bleeding, especially if you have a pregnant patient. Just do 180 degrees if someone's pregnant. To prepare the liquid specimens, you take that broom and you put it into the container. This is the brand that I told you, it's a smaller vial, and you push this head off into the jar and close it up and send the jar with that head inside. For this brand, you take the broom and you smush it around in the jar a lot to release any of the cells that might be stuck to the brush, and their brushes don't come off. So they're different brands. We prepare it a little bit different. Make sure you know how to use the equipment that's in your clinic. Watch videos, go on the manufacturer's website, and they'll show you how to do it. This is how to prepare a slide. We don't do them anymore, so I'm not even going to spend any time on it. But we used to smear it onto a slide and fix it with a fixative, and that's why it got the name Pap smear. Um, Cytology requisition. This is super important, and a lot of us are dependent upon our medical assistants to fill out the paperwork for us. We need to check it because we know what we did and we know what the patient's history is. The MA may not really know. So you want to make sure, first of all, you have the right patient, that they've got the name on it and you've got the name on the jar. The worst thing ever is to have some horrible result come back and you don't know who it is. Or you've labeled it wrong and the wrong person was called, and the one who's got this progressing potential cervical lesion is out walking around somewhere on the planet and you don't know how to find them. Make sure the jar is labeled and the requisition is labeled correctly. And we want to know if they had previous OBGYN procedures. Do they have a history of abnormal cytology? The lab will pull old slides and send them to the pathologist and compare current slides to old slides. But we have to tell them that, hey, this person has had an abnormal smear before, and we need to tell them where it was done. If it's at the same lab, we need to give them the number off of our results. So let the lab know what's going on with the patient. If you just do everybody like a screen, like nothing ever happened before, you don't get that follow-up on the patient. All of those slides are saved, so they can be re-examined at a later date. So make sure also if there's any kind of indication for doing this exam, if there's abnormal bleeding, they're going to look for endometrial cells. They're going to take special care to look for endometrial cells. If the person had an abnormal pap smear, they're really going to pull them after the computer screens them, and they're going to put a human on there to look and double check and see if they see anything. Um, if there's postmenopausal bleeding, they're going to be looking for endometrial cancer cells. So make sure you let your pathology people know what's going on. This isn't just sending off to a lab like a blood vial where we know nothing about the patient. They need to know, because it's not running just a blood test through a computer that's counting the number of red blood cells. They're looking for specific changes, and there's a computer screen, and then there's human eye screens, and then there's a pathologist physician who can do another check of them. So let them know what they need to do. We need to tell them the date of the last period. And the reason is, if they're bleeding, then we're not going to be concerned about endometrial cells. We're going to expect endometrial cells if someone's on their menses. But if they're not on their menses and we're seeing endometrial cells, maybe there is some endometrial cancer getting started in there. Why are there endometrial cells in the cervix? There shouldn't be unless she's on her period. So give this information. There's a history of condyloma, let them know. Certain medications, let them know. Is she pregnant? Is she postmenopausal? Is she postpartum? Tell the pathologist what you're specifically looking for. Is she taking birth control pills? Does she have tamoxifen? Does she have herpes? Is there an IUD? Let them know. So that's all I'm really going to talk about with that. The ASCCP guidelines, you can Google this and you can look on their website. It's not nearly as fabulous as it used to be, but it does still exist. So we do have, this was initially written in 2015 where we could do just primary HPV screening instead of PAP and cytology and HPV testing. There are indications where we just do pure HPV testing with no cytology. If you screen someone for HPV, now this is for primary screening, but now we're also doing cytology plus HPV screening for people over 30. So we would check them for high risk HPV. Do they have high risk HPV, which is usually 16, 18? There's a couple more. There's other high risk, those are the other high risk HPV. and then there's negative for HPV. So if someone is negative for HPV, we just put them in routine screening. If someone has high risk HPV for 16, 18, we do colposcopy. If they have anything, okay, if they have another type of HPV, other high risk HPV, we do cytology. So now instead of adding HPV to the cytology, we add cytology to the HPV test. If it's ASCUS or higher, we send them for colposcopy. So if it's high risk 16, 18, we do colposcopy. If it's other high risk HPV, we do a cytology exam. Depending on the results, we'll send them to colposcopy. If it's normal, we follow up in a year. If they don't have high risk HPV, then we just do routine screening, which is every 5 years. So this was a great article on the screening guidelines, which is basically what I said of no screening until someone is 21, between 21 and 29. Cytology alone every 3 years is fine. 30 to 65, we do HPV and cytology co-testing every 5 years. That's the preferred test up to age 65. And if someone has a history of abnormal cytology or cancer in the past, we would continue to screen them for 20 years after their last exam. And after hysterectomy, we don't have to screen them, especially if it's a hysterectomy for a non-cancer reason. If they had a hysterectomy because of cervical cancer, we might screen the cuff, which is the part of the back of the vagina that's closed off after a hysterectomy. So this is just what I said. When to screen. Okay, you can take a snapshot of that slide because that's basically what we're doing. So this again, these are the squamous cells. I already showed you this picture, and this would be negative. This is normal squamous cells. No concern here. This is no cancer. Again, these are the columnar cells and the squamous cells. They all look normal. They have small nuclei and large amount of cytoplasm. These are normal. Again, don't pay attention to the red or the blue. I don't know why they do that. There's a reason. I've been to a lecture with the cytologist, and there's a reason. I don't remember what it is. It has nothing to do with me, or you, so don't worry about it. Abnormal screening results. If you have someone who has an abnormal result, now what do you do? How do you follow up on that? Well, the first thing is it listed as an unsatisfactory? Maybe there was too much gunk in there. Maybe you didn't get a sample that they could see. Maybe there's less unsatisfactory results with the liquid cytology that I showed you. When we used to do smears on a slide, we had a lot more of these. So just look at the lab test, the result, and see what the reason was. And depending on the reason, you would take action. So if there's not enough cellular material, or if there was too much artifact to read, they'll tell you on the result, and then you can repeat it. This is a sample. These were actually from smears, so this is old. But it was air dried, and there's a lot of blood in here, and it's hard to see. A lot of bright red blood cells in the way to see. This is dried, and it's real air dried. It's really hard to see what's going on. These are a lot of white blood cells. These are polys, and so we're worried about what's underneath those. We can't see what's underneath. We can't see the cytology. We can't see the epithelial, the squamous epithelial cells, because there's so many white cells on top of it. And we really want to know, why are there so many white cells? What's going on? What kind of infection is there here? If you don't get any endocervical cells, those are the cells that are lining the endocervical canal. That is something that will show up on your report. If the person is aged 21 to 29, we just keep them on their same routine screening. If they're age 30 or above, find out, was HPV testing done? If the HPV testing was done and it was negative, just send them back for routine screening. If they had HPV positive, we want to see, is it high or low, high risk or low risk HPV? and then repeat repeat the cytology and repeat HPV test in a year. If HPV testing was not done, because we don't always pay for co-testing, even though that was the recommended guideline to do both HPV and cytology testing between 30 and 65. We don't always do it, it doesn't always get done every 5 years. So if no HPV testing was done, do it. They could do it reflexively, call the lab, see if they'll do a reflex HPV, or bring the patient back and send an HPV test. Um, or you can repeat the cytology in 3 years. So those are the issues if there's no endocervical cells. So really try to get the endocervical cells. When you do a smear, scrape the area that you think has endocervical cells and scrape the area of the junction. Age 21 to 24, we don't do HPV testing because we assume they're all going to be positive. So we don't want to identify someone who has HPV who's under 30 because we're not going to do anything about it. We would rather just not test. We just want to do cytology and make sure there's no abnormal changes. If there's abnormal changes like ascus or low-grade SIL, we can repeat that in a year. And if they've had three tests that are normal, we just put her back to normal regular screening. If those results come back in the repeating results, if they get a repeat ascus or a repeat low-grade SIL, we need to send that patient for colposcopy where we can do a biopsy and see what's underneath that area that keeps testing positive. And we can always do a reflex HPV, and that means if the test is positive, cytology is positive, the lab will automatically do an HPV test. That test costs more than just paying for just a cytology test. So that's something you need to work out with the insurers. Sometimes you need to work it out with the patient. Maybe they have insurance, maybe they don't have insurance. So that becomes a cost factor. But ideally, you'll have reflex HPV testing done on any abnormal cytology test. This is the same picture, same progression, or a same cartoon description of what I showed you before with the normal cells, normal epithelium cells, tiny nucleus, big cytoplasm, growing nucleus. The cytoplasm is getting smaller, and this is a huge nucleus. CIN3 is pretty much synonymous with carcinoma in situ and beyond. So metastatic cancer can also be look like CIN3. So these are some pictures of actual cells. Can you see that these nuclei are bigger than, say, let me go back to my pin, than these? This has like big cytoplasm with pretty small nucleus or nuclei. This one has bigger nuclei. Not all of the cells. And here, this is much smaller, right? Much smaller amount of cytoplasm with a much bigger nucleus. These ones too. So it's not every cell, but you're starting to see these larger nuclei. These don't really concern us. We don't check this, but this is what's being looked for at the lab. And here you're seeing even larger nuclei, less amounts of cytoplasm. These are very large nuclei, like this is huge with a small amount of cytoplasm. All these kind of dark blue things are white blood cells. And here, these are pretty big nuclei with small cells. So these are getting more and more scary. And this has very little cytoplasm. Okay, great big nuclei. This one looks like multiple nuclei perhaps inside a cell. This is a giant nucleus with hardly any cytoplasm. And these are all nuclei. There is no cytoplasm over here. And then these are normal cells out here. So when you get a pap smear, you're not going to just get every single cell being abnormal. There's going to be some that came off of the lesion, and we're going to see that. But then there's also some normal cells around. So that's normal. But you want to make sure you sample the area that's most likely to have the abnormal cells. I don't really want to go over exactly what to do because those will be in the guidelines and you can look those up, and these do change on how you're going to follow up on abnormal cells. So this is going through high risk, high grade SIL. We refer them for colposcopy. And like I said before, if you have AGUS, which is atypical glandular cells of undetermined significance, they always go to colposcopy. Ascus are atypical squamous cells of undetermined significance. And what we're concerned about those, it's not really a low grade or a high grade lesion, they can't tell. And so that's why we want to retest them over a period of time. And if it comes back abnormal on the second one, then we want to make sure we do the HPV testing and maybe do a colposcopy and see if there's something lying underneath that ascus lesion. I already talked about AGUS. Here it is again, because I don't want you to forget about it. It's really important and it's pretty rare. And just because you're not sure what it means doesn't mean you should just skip over it. It's super important. Other things that might be found and reported on a pap smear are atrophy. Postmenopausal women who have very little estrogen effect on the squamous cells, they have atrophic changes, and those can be identified on a pap smear result. Inflammation can be identified, which would look like lots of white blood cells. Infection, perhaps they see yeast forms on the slide. Perhaps they'll call it a shift in flora suggestive of bacterial vaginosis. That's where you see lots and lots of abnormal tiny little dot bacteria in the background instead of nice lactobacilli of the normal flora of the vagina. They might see trichomonads, which would indicate a trichomonas infection. Actinomyces is a type of fungus, and sometimes we can see that happening in women who have had IUDs for a lot of years. So that can show up on the cytology result if there was actinomyces seen, and that needs to be treated. And there can be multinucleated giant cells, and that would be an epithelial cell that has multiple nuclei in it. And that is often indicative of a herpes virus infection. So it's also called a Zank smear. If you just send something off for a Zank smear, they're looking for these multinucleated giant cells. So it's a giant epithelial cell with lots of nuclei inside. And then they're also looking for endometrial cells. These are pseudohyphae. So this is associated with yeast. You can see all this branching stuff going on here. This isn't very high magnification, so you can't see the little buds on it. And this is not a wet mount, but these are yeast, and the cytotech will report these out on the cytology report. Trichomonads will be reported out, and they can tell, even though they're not motile, they stain different than the cells, and the cytologist can tell when trichomonads are there. So if you have a patient with no symptoms and trich shows up on their pap smear, trust it. You can treat the patient for trich with the result on their pap smear. Actinomyces, that's the fungus that I talked about. That's something that can be identified by the cytologist. And this is a picture of the multinucleated giant cell. You can see it's a great big huge epithelial cell. Here's a normal one, here's a normal one. And it's got 1, 2, 3, 4, 5 nuclei inside. And that is associated with herpes. Herpes infections tend to do that. So diagnostic testing, remember the diagnostic test takes a subsection of the general population that you have screened, and you do the next set of tests to see if you can come up with a diagnosis for your patient. So it will help you identify what the illness or condition is. The diagnostic testing is usually more expensive than a screening test, and there could be risks, like it could be painful or it could be expensive. It could take a longer time. There's several things that could be involved with it. So the diagnostic test for an abnormal pap smear. This is my last slide. I thought I had slides on showing what the oh, I do. Here's the colposcope. I don't know why I didn't see it a minute ago. This is one style of a colposcopy, of a colposcope, which we use for a colposcopy. It's like binoculars. This is the eyepiece. This whole head turns any direction. So this turns towards the operator, and there's two eyepieces. Like here, you put your eyeballs up here, and it's like looking through kind of a microscope. And there's a bright light on it, as we saw by the light reflection. And the operator looks through and puts vinegar on the cervix, looking for aceto white changes. So the vinegar makes certain parts of the cervix turn bright white. They look at those areas, look for other things that may indicate cancer or precancer, and take a biopsy. And so it can be pretty uncomfortable to have this done. We would prefer people to not have to have this done. And if people are immunized against HPV, they don't have to go through this because they're not going to have a problem with this infection. We also do an endocervical curettage. We take another instrument and enter the endocervical canal and scrape around there and get a sample of the tissue up in the canal to make sure there's no abnormal lesion going up to where we can't see it and up to where we can't easily treat it. For treatment, we can freeze the lesion. Most commonly these days, we're using a LEAP or a LETS procedure. This is like a proprietary name, but they're the same thing. This is an electric wire on a plastic gizmo on a stick. And you take this loop and you cut it through this portion of the cervix and actually remove a piece of the cervix, like you can see here. So you put it up, you bring it down on this angle, remove this piece of tissue, you have this entire chunk of tissue that gets sent to the lab, and they test it, they look at it, they cut it up, freeze it, look at it, and give you a result. And the abnormal cells have also been cut away. So this is both a diagnostic test as well as a treatment. But this is not something we really want to do in women who have not completed their families, because this can cause some issues with the cervix staying closed, as can freezing it. So that's why we want to avoid treatment in young women if possible. If someone has progressive HPV disease, we want to treat it so they don't develop metastatic cancer. We want to prevent cancer. So that's a conversation that you would need to include the patient in, as far as would you like to have children and what are your plans? We want to do this treatment. We would rather not do certain things if you're planning to become pregnant. What's the plan? Maybe she's planning on being pregnant next week or next year. Maybe she has no plans for pregnancy. Maybe, depending how extensive the issue is she has, there's an option for women to freeze their eggs and then to have surgical procedures, which would eliminate the possibility of them carrying a child, but they have frozen eggs, which could be implanted in a surrogate. So that's another possibility. So think about people's plans for pregnancy. Um, like I had said, we could freeze the lesions with cryotherapy. There's also laser therapy. They could have a complete hysterectomy. And pretty much the most common treatment, I think, has been LEAP, or the LETS procedure, or the LETS cone biopsy, which is, I showed you the picture of that, because it gives you a good chunk of tissue to read for the results, and treats it. These came from, some of these are kind of old, because this was showing the progression of how our testing has evolved over time. And that is all I have now. So I thank you for your attention, and I hope that helps to give you more background on cervical cytology and how to collect your specimens. Thank you.